Okay, everyone, good morning. Our speaker today is Dr. Jennifer Wilson, DO. Our program is underwritten by an educational grant through the OSU Medical Center Graduate Medical Education Office. A disclosure statement has been signed and is on file in the Graduate Medical Education Office. Jennifer Wilson, DO, joined the Department of Osteopathic Manipulative Medicine at Oklahoma State University Center for Health Sciences in July 2016. She is a graduate of Nova Southeastern University College of Osteopathic Medicine, located in Fort Lauderdale, Florida. She completed her residency in family medicine at Largo Medical Center in Florida, followed by a +1 residency in neuromusculoskeletal medicine and osteopathic manipulative medicine at OSU. She is board certified in family medicine and NMM OMM. She currently serves as the clinical assistant professor at OSU CHS and is the course director for OMM 1 and OMM 2. Please welcome Dr. Jennifer Wilson.
Good morning, everyone. I'm so excited to be here. Most of you guys know me already. And today we're going to talk about an osteopathic approach to coccydynia. So our objectives for today is to quickly define coccydynia and review the relevant anatomy and discuss a little bit about the etiology and clinical presentation for those patients that show up with coccydynia, and then talk a little bit about those physical exam findings and the workup to be considered, and then go into possible treatment options, including OMM, as well as spend some time on the previous and current research regarding coccydynia. So why this topic? Well, it's one that's gotten a little bit more attention in recent years because overall there's really limited research on it. And definitely minimal research within the osteopathic medicine world. There's a varied pathophysiology and treatment protocols, especially when it comes to chronic coccydynia, is really ill-defined, especially for conservative management. And while the prevalence is low, maybe thought to be about 1 to 3% of all complaints of the spine, it definitely can have a large impact on the quality of life, especially when a lot of those patients are in their 30s or their 40s. So there's also a little bit of a misunderstanding regarding the care for coccydynia. In 2013, they did a survey of primary care providers, and they found that only about 50% of them felt that they would be able to correctly diagnose coccydynia. Only 22% would provide a referral for chronic cases, which should definitely not be the case. And while surgery is a really effective last resort for coccydynia, only 10% of them believe that it would be effective. It changes a little bit when you start going to some of the specialty services. They did a survey last year on all physicians providing any sort of OB services, so mostly your OB and family med docs, and about 70 to 80% of them would refer for OMM specifically for coccydynia, but really during that pregnancy time frame. But there was a big reported barrier to access. So what is it? Well, it's really, oh, what happened here? Let's see. Here we go. Okay, looks like you got my screen back, I hope. There we go, perfect. So the definition for coccydynia is really tailbone related pain, and it should really be localized to that area. Some people include areas for radiation, and it can radiate to the lower legs or genitals, but really the kind of pure definition is pain that is really localized around that tailbone. It was first termed in 1859 by J. Simpson in the Med Times Gazelle. However, there are a few accounts that date back to the 16th century. The exact incidence is unknown, but much more prevalent in women, 5 times more likely, and definitely more common also in adolescents and adults rather than children. The risk factors is trauma, pregnancy, female, low back pain, if they're obese or had a sudden rapid weight loss, osteoporosis, degenerative joint disease, and somatization disorder are also risk factors. Some potential causes, for the most part, we stay in that kind of either major or repetitive microtrauma as a potential cause for coccydynia. For the major trauma, falls or childbirth are the top two. They can cause fractures, dislocations, but also just contusions to that area. And for the repetitive microtrauma, we can see things like incorrect posture or prolonged sitting. Sometimes certain athletes, such as cyclists, can develop coccydynia as well. You can see some partial dislocations from these cases, but those two categories fall into this kind of circle of inflammation, granulation tissue adhesions, and just this overall change of the tissues surrounding the coccyx. Other possible etiologies that could be non-traumatic would be degenerative joint disease, where you can see the osteophyte formations and sometimes spicules on x-rays, infection, avascular necrosis, or oncologic sources. Referred pain to the coccyx can also occur either from the pelvis, lumbars, from cysts, hemorrhoids, prostatitis. And then we have our psychologics, metastasization disorder, and of course, idiopathic. So a little bit about the anatomy so we can have a good idea about what we're thinking about here is the coccyx itself is a word that's derived from a Greek word for the beak of a cuckoo bird because of its shape with that kind of curved beak. It can be anywhere from 3 to 5 segments, the largest of which articulates with the sacrum. And that first segment contains these cornu that are rudimentary articular processes that articulate with the sacral cornua. It lacks a vertebral canal, CSF, and neuroforamina, but it does have that insertion point for that phylum terminality. Function-wise, it's obviously an insertion site for ligaments and muscles that all contribute to helping to enable voluntary bowel control, affect sexual function and posture, and support the bladder and uterus. It's also our weight-bearing support for when we're sitting, so part of that tripod with the ischial tuberosities. And so it's going to absorb pressure shifts when we're seated and leaning forward and backward. So ligaments, we already mentioned that phylum terminale that it's inserting on that first segment, but then we have portions of that sacrotuberous and sacrospinous ligament that are going to insert laterally on the edges of the coccyx. And then we have 3 sacrococcygeal ligaments, the anterior, posterior, and lateral. So here we can see portions of that posterior and lateral sacrococcygeal ligament. And then anteriorly, you can see how the anterior sacrococcygeal ligament crisscrosses over as well. Muscular attachments. Anteriorly, we have the coccygeus muscle and then the levator ani, coccygeus coming in laterally and levator ani being more at the distal aspect of the coccyx. And then from the posterior aspect, we have the glute maximus that's going to attach, and then the sphincter ani. So I have some pictures here. This is from the anterior aspect of the coccyx. So we have coccygeus coming in, running from that ischial spine and margin of the greater sciatic notch to the 4th and 5th sacrovertebrae, and then to the coccyx. And then for the levator ani, it's got those 3 parts: iliococcygeus, pubococcygeus, and tuba rectalis. And they're going to kind of flex that coccyx as well and contribute to some of the motion of it. And this is that posterior view with the gluteus maximus coming in laterally and attaching, and then the sphincter ani coming from that distal portion and attaching to the coccyx. So innervation deserves a little bit of mention because it's a little bit more complex here. It's going to be mainly coming from those lower sacrospinal nerves and the coccygeal nerves, which derive from that lower sacral nerve roots. So anteriorly, we have innervation from the sacrococcygeal plexus, and those afferent fibers are going to pass through the coccygeus muscle and sacrospinous ligament. And so it's going to be supplying sacrospinous, coccygeal ligament, skin and soft tissue of the ventral coccyx, the external anal sphincter, and then the sacrococcygeal joint, that first joint, the coccygeal periosteum, and anterior musculature. Posteriorly, we've got those paired coccygeal nerves that are going to join with the posterior rami of the fourth and fifth sacral segments, and then go down to innervate the skin and soft tissue of the dorsal coccyx. So if you're thinking about falls backwards, for example, or trauma, that pain originating more from the posterior coccyx are going to be kind of typically associated with exquisite tenderness and difficulty sitting for a prolonged period of time. And so when we're thinking about treatments, where that pain is coming from, is it anterior, is it posterior, is it referred? If we're thinking about posterior originating pain, they may be cases where they're more responsive to interventional treatment, such as radiofrequency ablation, which is going to target those nerves. And then just a quick mention, you have those autonomics. Everybody thinking back to those viscerosomatic lectures where we have that innervation from the sympathetic nervous system coming down that paravertebral sympathetic trunk, and it terminates at the ganglion impart, which is just anterior to the coccyx. And so we have visceral afferent fibers from the rectum that travel along with the sympathetic fibers. The visceral pain is typically pretty poorly localized, but it definitely can refer to the coccyx. And so there are treatments such as ganglion impart injections and pulse radiofrequency ablation that can be a treatment and therapeutic option for coccydynia. So just another mention for referred pain that maybe comes from more the pelvic viscera, they're going to be passing through that hypogastric plexus that contains sympathetic fibers. And to a lesser degree, we have the pelvic splanchnic nerves carrying parasympathetic fibers from that second, third, and sometimes fourth sacral segments. Okay, so coccyx on average is about 4 centimeters. We have an intercoccygeal angle, which is that angle between the first proximal and most distal segment, and it's supposed to kind of curve a little bit forward. Average angle is about 138 degrees in males, 147 in females. But there's a really large variety in morphology. So it's been classified into types. This was originally postulated by Coccydynia and Massabrio in 1983. And this classification really is still used today as the mainstay. The way I did it, they took x-rays of 120 patients without pain, just put them into groups. And so the most kind of normal that we think about is that type 1, where the coccyx is just a little bit curved anteriorly. Type 2, 3, and 4, which tend to correlate more consistently with coccydynia, has variation to it. So type 2, which is second most common, just has a little bit more of a forward curvature. It's a bit more dramatic, and that apex extends forward. Type 3 has a sharp angle to it, so it really comes almost like almost a 90-degree turn in there. And then type 4 can be some variation of either extended, subluxated, or something kind of different at that sacrococcygeal joint. They did expand this classification a few years later, but I wouldn't say it's really used all that much. But basically, it kept type 1, 2, and 3 the same. And then type 4, they kind of split up into either anterior subluxation, retroversion, or type 6 being some sort of scoliotic deformity. But for the most part, when you're going to get x-rays on the coccyx, they're going to follow that type 1 through 4 classification. I did want to just mention this in case you ever see it. There's something called a pelvic incidence, which is that angle formed between the sacral base and the axis of the femoral heads. Type 3 and 4 are associated with higher pelvic incidence angle, which also then correlates with a higher rate for patients going through coccygeal excision. So along with the type and shape of coccyx, we also need to think about motion and how that coccyx is functioning. So a normal coccyx should move into flexion when you go into a seated position. The average range for the amount of flexion that should occur should be anywhere from 5 to 25 degrees. And we measure that using that angle of incidence, or that angle of where the coccyx strikes the seat when the patient sits down. So we're looking at lines from the anterior surface of the distal sacrum and anterior surface of the coccyx. So a smaller angle means that there's a lot of flexion, and a larger angle would mean that that coccyx is a little more perpendicular to the seat and that there's less flexion. So here's some x-rays, and these kind of standard coccyx x-rays, you also are going to be looking for fracture dislocation, hyper and hypermobility. But once you're getting that, there's a certain way in which they kind of need to be done. So ideally, when you get these x-rays, you want to have the patient standing for about 10 minutes to kind of ensure that coccyx is in a neutral position. Get your x-ray, and then have them seated on a firm surface, slightly leaned back. Yes, a little painful, especially if they have coccydynia, but just real quick to get that x-ray, and then you calculate your motion. So once you've done that, then you can put it into one of 4 groups. I'm going to call him Dr. M, because even though I've had years of French, I do not know how to pronounce his name. So Dr. M, who is a French rheumatologist and PM&R specialist, he classified motion of the coccyx into one of the 4 following groups: luxation, which would be backwards displacement when the coccyx when the patient goes to sit; hypermobility, more than 25; hypo, less than 5; and normal, sticking to that 5 to 25. And so he also did a small study in '96, and basically looking at patients with coccydynia, seeing, where these patients fall into. And the 2 most common groups for those with coccydynia were group 2, which is hypermobility, and luxation, which is that backwards displacement. And I would definitely say that's been echoed quite a bit in all of the research that has been done on patients with coccydynia. So how do these patients show up in your office? Well, the typical backstory is either a premenopausal female with some sort of history of childbirth, or a patient that has lingering pain after an acute fall backwards months to years ago. Obviously, coccydynia, they should have pain with palpation of their coccyx, especially with sitting, and especially on hard surfaces. Worse with leaning backwards, because you shift that weight onto the coccyx when you do that, and when sitting for long periods of time. Associated symptoms could be dyspareunia, pain with defecation, and then changing position can also cause some pain. And that pain should get better when they're standing and walking around. So you have that. Now, what do you do? Well, physical exam would be next. So obviously inspect for gross abnormality, erythema, skin breakdown. You want to make sure there's not rashes, fistulas, sources of infection that may be there. If you do visualize a dimple that can be seen over the distal coccyx, that often correlates with a bone spur formation. And then on palpation, you want to be looking for tenderness, exactly where that tenderness is, step off, fluctuant masses. And then basically how you do that is you can find that sacral hiatus that has the cornua. Just kind of walk your fingers down along the posterior aspect of the coccyx. Point tenderness at the distal tip should raise concern for possible degenerative osteophyte formation. But a big thing here would be that if there's abscess of tenderness on palpation, then you're thinking a lot more about this is really a referred pain from either pelvic or lumbar structures. If more in-depth palpation is necessary, you can definitely evaluate the coccyx for mobility. That's going to need to be done intrarectally, and basically you just grasp the coccyx between the thumb and forefinger. And then, since you are basically doing a rectal exam at that point, then you can also be evaluating for hemorrhoids, masses, prostate hypertrophy, and then pelvic floor trigger points can also be done as well, although that can be done intravaginally as well for some of those pelvic floor trigger points. But don't forget, the rest of the exam is definitely just as important. Range of motion and a structural exam of the hip is definitely indicated here. You want to be assessing the lumbar spine for facet arthritis, degeneration, somatic dysfunction, as well as the sacrum. And then everything around it, those pelvic muscles and ligaments, for example, sacrotuberous ligament, you're going to be looking for hypertonicity, tissue texture changes, trigger points within those pelvic muscles. And then the piriformis and psoas has been linked to coccydynia as well. So you may not immediately think of those two because they're not really maybe going directly to the coccyx, but those are two muscles that you'd want to quickly assess as well because of how they contribute to that structural integrity of the pelvis itself. So for trigger points, here's just a little bit of a visual of seeing those trigger points within the levator, ani, and coccygeus muscles on the left, and then the trigger point for the obturator internus, that you can't really evaluate unless it's intravaginally or intrarectally. That is on the right side of the screen, but you can see both of those trigger points will refer pain straight to the coccyx. So imaging, we already talked a little bit about those dynamic x-rays, which are important. You could also consider x-rays of the lumbar spine and pelvis. MRIs are often obtained with and without contrast, especially if there's concern for tumor, abscess, infection. Make sure, of course, you're including the entire sacrum and coccyx. Tarlov cysts are common, the CSF fluid-filled sacs that contain nerve roots and can be symptomatic and radiate pain to the coccyx. And then more rare, but definitely possible, are these primary coccygeal tumors, these chordomas that can be right at the coccyx, and oncologic issues such as renal cell carcinoma metastasis as well can go to the coccyx. And this patient on the right that had the chordoma, typically that's a poor prognosis, but this patient had coccygyectomy and a total resection actually did fine. CT is less common, but could be considered if there's significant trauma. And then labs, again, not typically done, but if you felt necessary, you could consider CBC, inflammatory markers, and then also fecal occult. All right, so treatment. Conservative treatment is really 90% effective for acute cases of coccydynia. So less than 2 months, something's happened, they have coccydynia, and often doesn't need a bunch of intervention and will kind of disappear. And you would really need 6 weeks of conservative therapy before even considering any further invasive steps, just from an insurance standpoint as well. It's the chronic coccydynia that's really difficult to treat and has poor outcomes. If trauma is involved, it's more likely to be easier to treat, but chronic coccydynia in general is really difficult, and a multimodal approach is 100% what you need to be doing. So the osteopathic mindset is perfect for that. So when you have these patients, think about that 5-model approach. How are you going to help this patient from a structural, neurologic, respiratory, circulatory, behavioral, and metabolic standpoint? OMM is appropriate for both acute and chronic patients, but you want to be choosing your techniques based on the suspected etiology of the pain. Make sure you've ruled out fracture prior to treatment. And you're not just going to obviously be thinking about OMM to the coccyx. We want to be considering lots of different areas: lower extremity, lumbars, pelvis, sacrum, cranial from that craniosacral standpoint, as well as cervical, thoracic, and then also everything else around it. The articular standpoint, how we're going to treat that, ligaments, muscles, fascia, lymphatic, how are we going to help our patient in as many ways as possible. So here are a list of lots of different things that you can consider for your patients with coccydynia. From a more conservative standpoint, we have rest, avoidance sitting, heat, ice, baths, pillows, TENS, OMM, PT, pelvic floor, massage, chiropractic, cryotherapy, behavioral, and then going to the next step, medications, extracorporeal shockwave therapy, trigger points, other types of steroid injections, ganglion blocks, prolo, PRP, stem cell, radiofrequency ablation, spinal cord stimulators, and then last but not least, coccygyectomy. And those with stars on it, we're going to kind of go into in a little bit more detail. So just a mention on conservative therapy. Obviously, avoidance of sitting or putting pressure on the coccyx is a definite first step. And the U-shaped or V-shaped pillows are what you want to be using. Really don't want to stay away from the donut pillows just because they restrict the range of motion of the coccyx and may add more pressure than the other types. Some patients have used TENS unit. There's not great studies to support that, but risk-benefit wise, it's probably not going to do any harm. Could be something to consider for chronic coccydynia, and that's just having those low voltage electrodes applied to the surface of the skin. Extracorporeal shockwave therapy, that's when we're delivering these shock waves, these kind of impulse waves to the injured tissues. The theory behind that is to reduce inflammation, break scar tissue, and stimulate healing. This has really been used a lot for tendinopathies and fasciitis, tennis elbow, golfer's elbow, plantar fasciitis. And so there are a few reports out there on using this for coccydynia, but there's really no good research on it. But again, probably not going to hurt either. Pelvic floor therapy, and we're lucky in Tulsa, we have a lot of pelvic floor therapists that are really well trained. And this is going to be a good option for our chronic cases. The goal of pelvic floor therapy is to relax and stretch overactive muscles, release trigger points and fascial restrictions, as well as retrain that lumbar, spine, and pelvic girdle. They will typically do manual intrarectal and intravaginal massage, and then also do some training on diaphragmatic breathing, reverse Kegels, and may or may not use dilators depending on what's going on. And their focus is going to be on the levator ani, coccygeus, and piriformis. So this is going to be ideal for coccydynia that's associated with muscle spasms, and there's no indication of instability, fracture, or osteophytes. And these, obviously, we want to be using pelvic floor therapists that had the appropriate specific training and certification. And there is a few studies out there to support this. 2016 had a study with 79 patients that had 9 sessions of pelvic floor therapy, and their average decrease in pain scores on the VAS scale was from 5.08 to 1.91 after just 9 sessions, which is quite significant, especially for patients sometimes that have had coccydynia for years. Medication options. I mean, we have all sorts of options, and there's no treatment protocol to really go by. NSAIDs are often frequently prescribed initially, especially more in that acute phase. But really, you can be choosing medicines and NSAIDs by patient preference, comorbidities, and medication tolerance. There is some research that supports efficacy for up to 3 months use of NSAIDs in chronic coccydynia. But I just kind of want to throw out there that there are some studies, for example, this one from 2004, really only show that NSAIDs benefited in 13% of cases. And if you're having that trauma or fracture, do you want to use NSAIDs or not? Is it going to affect the risk of non-union if there's fracture? Again, controversial, but something to consider. And then topical versus oral. For coccydynia, topicals have shown to be just as effective as oral NSAIDs. Strongest evidence for use is diclofenac and ketoprofen. But if you want to stick with the orals, you've got large options for you: ibuprofen 600 3 times a day, naproxen 500 twice, or meloxicam once daily. Really up to you on what you want to do. There's no specific one that has been indicated. Muscle relaxers, not very much support for coccydynia. However, I kept that in here because if you're having coccydynia that's really related to pelvic floor spasm and pain, that would be appropriate. So your flexurils, Robaxins could be a choice. Gabapentin and Lyrica, if you're having more of a neuropathic pain. Gabapentin we use often in chronic pelvic pain. So if you are going to use that, just remember to start low and titrate up. And then tricyclic antidepressants and amitriptyline we use sometimes with myofascial pelvic pain. But it can also, the nice thing is it can help with sleep and depression that are comorbidities that we see in coccydynia as well. So 75 milligrams at night, just keeping in mind that that average peak effect isn't going to really take place until about a month in. Some alternatives here. Intranasal calcitonin for acute pain from fracture, capsaicin for neuropathic, Cymbalta, of course, for our chronic musculoskeletal pain patients or poor response to other medications. And if you are going to use opioids, if you have a situation like fracture, malignancy, infection, obviously stick to the lowest dose for the shortest period of time. So steroid injections, a couple of different types, indicated for muscle spasm, unstable joints, and then also useful in degenerative joint or spicular formation cases. And we have trigger points that are going to be injected right to that belly of that muscle at that trigger point. You can do steroid injections to the sacrococcygeal ligaments around the coccyx, or you could also do a sacrococcygeal joint injection. This would be under guidance, either ultrasound or fluoroscopy, and those can be quite effective, typically for 2 to 4 months, sometimes much longer than that. And if they are highly effective and they're good, it's a good prognostic indicator that this patient may be a candidate for radiofrequency ablation or also have a lot of relief from a coccygectomy as well. And overall, from trigger points and coccygeal ligament injections and overall steroid injections to the coccyx, that success rate is a moderate improvement in more than 50% of patients. So if you're going to do this, you definitely want to give that option that, hey, this may or may not be helpful. And so that ganglion is impar, that very distal where that sympathetic chain ends from that paravertebral chain, that's where that will end, right at that level of the sacrococcygeal junction. And it's going to innervate that perineum, distal rectum, anus, urethra, vulva, and distal third of the vagina. And those injections can lead to immediate relief of pain. If you are going to do it, it's obviously under imaging, but you can expect quite a bit of improvement if it does work for an extended period of time. There is some research out there that can argue for, instead of doing that injection at the sacrococcygeal joint, to maybe use a different location, for example, the first intracoccygeal joint instead, because sometimes we'll see fusion of the sacrococcygeal junction. And one of the studies that was done for patients with traumatic coccydynia that was refractory to conventional treatment, they had 21 patients, and they injected that ganglion with 1% lidocaine, 60 to 80 milligrams of triamcinolone, and about 16 of their patients had a reduction of pain of 50%. So here is just some imaging of that being done. You have that needle being placed, that contrast just to ensure placement. just anterior to the coccyx for that ganglion. Neurofrequency ablation can be considered, especially if those steroid injections and blocks have shown to be promising. Typically, posterior adjoining pain is going to be more amenable to interventional treatment, such as neurofrequency ablation. There was a study in 2016 that showed pain relief in 55% of patients that had Coccydynia for an average of well over 3 years. They did conventional and pulsed radiofrequency ablation, no major difference shown between those. And then another study with 21 patients that had all pulsed radiofrequency ablation, their median score pains went from a 9 to a 4. But 5 of those patients did go on to a coccygectomy after intervention. But again, the problem with a lot of these studies, they're small, there's limited information, and a lot of these don't have placebos or controls. So it's really hard to compare how these patients would have done without intervention. Alternative treatment options, prolo, PRP, stem cell. There's really not any studies to support using this or to back this up. However, if you have patients that are not able to tolerate steroids and they're in a setting that you have fracture or dislocation or instability of that coccyx and they don't really want to go on to surgeries, then this could be something to keep in the back of your mind. So for that coccygectomy, that last resort for the patients with continuous pain and failed conservative interventions, the coccygectomy is definitely an option there. Post-op complications are infection, which is on average reported 10%, delayed wound healing, osteomyelitis, and pelvic prolapse. However, the success rates are high. They're, greater than 75%. Yes, the studies in most part are observational, retrospective, and uncontrolled, but this definitely in general is a treatment option that has some of the highest success rates over all the other treatments that are available. And the group that really is leading a lot of the research on this is a group from Norway, Karlstedt and her colleagues. They did a retrospective study of 171 patients who'd all failed conservative therapies. They underwent coccygectomy, and then at 1 year follow-up, the success rate was 71%, which is being defined as completely well or much, much better. But 89% of them would have done that surgery again if they had known the outcome. So that's pretty high. Then the other interesting thing about that study is they ended up using 2 days of prophylactic post-operative antibiotics, and they were able to reduce their infection rates from 10% down to 2%. All right, so OMT, what are we going to do? So some options that we have for OMT techniques we're going to kind of describe. The first kind of techniques that are at least documented here is from Dr. Tavel in 1975. And he's basically holding the coccyx from an anterior posterior direction with a finger and thumb and moved it back and forth and kind of felt it slip into place. And then as well did massage of the musculature from midline to lateral and focused on that levator ani, coccygeus, and piriformis as well. And he, this isn't a very well documented study, but he basically self-reported that he would do 2 to 3 minute treatments once to twice weekly for 3 to 4 weeks and had relief in 75% of cases. We have other techniques. Dr. Hartman in 83 talked about articulatory muscle energy type of technique where he'd have the patient prone and basically abduct, extend, and internally rotate the hip to create a lot of tension of the musculature at the coccyx. And then using his thumb, he'd create counter pressure to that area to kind of mobilize things. Then he'd remove that extension, internally rotate the hip a little further, and kind of target more of the superficial tissues of the coccyx. And then some other soft tissue work that he did was kind of work his fingers into the tissues around the coccyx and pull laterally and posteriorly and hold for a few seconds. I'm sorry I don't have great pictures for that, but the steps are kind of there if you want to give that a go. Counter strain, can't forget that we have our counter strain options. Counter strain first proposed by Lawrence Jones in 1955 and published in the 80s. We have Herman Myers as one of our great writers of all the counter strain tender points. And he describes the location being on either side and the tip of the coccyx with an anatomical correlation to the coccygeus. When you're checking for tenderness, you're coming from lateral to anterior at that coccyx. And to treat it, he described it basically as applying pressure anteriorly to the apex of the sacrum, so the distal portion of the sacrum. And that kind of encourages a little bit of extension of the sacrum as well. And that is a somatic dysfunction that we often see in coccydynia, is more extended sacrums. And then he would rotate his hand that's on that sacrum toward, sometimes away, but mostly toward the tender point to kind of bring down that pain scale. And Cousineau's had a very similar treatment definition for counter strain as well. Patient prone, he would contact the entire sacrum and try to scoop it into extension. But in the end, again, the same point of trying to bring it into the sacrum into extension and then fine tune by twisting that hand either clockwise or counterclockwise. And then trigger points to evaluate for those. We have that sphincter ani, levator ani, and coccygeus going to the coccyx, and then obturator internus. We talked about those two. But then don't forget to quickly evaluate glute medius as well, because it can refer to areas pretty close to the coccyx as well. And you can treat those muscles in various ways. I definitely want to mention the piriformis and psoas as well, because they're not going to necessarily directly attach to the coccyx, but they have shown to be related to coccydynia. So piriformis going to be attaching anteriorly at S2 through 4, going to externally rotate that femur and with hip extension and abductive hip flexion. And then remember, spasms of the piriformis are going to affect sacral dysfunction. So if you have a right piriformis spasm, you're going to end up with a left on left sacral torsion typically. And then for the psoas, it's a major hip flexor and lumbar stabilizer, and unilateral contraction of the psoas on one side is really going to alter those pelvic mechanics and stabilization. And we can definitely see more sacral base dysfunction with psoas spasms as well. So maybe not directly related to coccyx, but a huge role as far as the stabilization and pelvic mechanics. There was a study done by Mahatny and Patnick in 2017. They had 48 participants, all adults with coccydynia. They excluded all sorts of etiologies such as cancer, cyst, tumor, surgery, fracture, trauma, or recent trauma at least, referred pain from lumbar, pelvic floor, degenerative disc, osteophyte. So really tried to get to this true definition of coccydynia. And they had put their patients into 3 groups. And each group had 5 sessions a week for 3 weeks. Group 1 was purely stretching the piriformis and psoas. That's it, along with not donut pillows, but just regular pillows and ice. Group 2, stretching piriformis, psoas, and thoracic mobilization, pillows and ice. And group 3 was just pillows and ice, and then phonophoresis, which is the ultrasound, sometimes with a topical NSAID, but no treatment for any sort of musculature, no piriformis or psoas stretching. And they saw significant changes in improvement for groups 1 and 2. So approximately 50% improvement in pain-free sitting. Unfortunately, we only followed them for a month, but at least 1 month later, that pain improvement was still there. So without even really touching the sacrum or the coccyx, they saw quite a bit of improvement in coccydynia. I think that really points to how surrounding pelvic musculature can really play a role as far as, treating that whole person. So treatment options, piriformis, remember counter strain, we have muscle energy, we have thumb stretches for the psoas as well. You've got that Thomas test that can then go into muscle energy, that counter strain position down at that bottom picture there, that flexion, side bending towards, rotation away, and then home stretches as well. And for my patients, they definitely get the home stretch regimen because I often only see them, once a month. So I really take that time to make sure that they can be doing some of these things at home as daily as possible. All right, so what research do we have to kind of support OMT use for our patients? So I'm going to start off with a couple of case reports. That first one being in 1977, Dr. Madeline, he had a 43-year-old patient with coccydynia that just started after a long bike ride. He did 5 days of OMT in a row, only treatment of the lumbars, nothing else, have complete resolution of pain. Then we had another case report in 2012, a 60-year-old female who had kind of failed the conservative therapies, had tried an epidural, failed that, then went on to lumbar and sacral manipulation under anesthesia with 50 to 70% improvement in her pain, had a repeat epidural, and then coccygeal manipulation under anesthesia. And those coccygeal manipulation included soft tissue techniques intrarectally, posterior pressure to the coccyx, and then OMT to the lumbar and sacrum. And she had 100% improvement in her coccydynia, as well as increased range of motion for her lower extremities. And then most recently for case reports, we have one done by Carabudo Alexandri and then Millicent Chanel in 2019 with a 21-year-old with coccydynia who's had coccydynia for 10 years from the fall backwards. There was a slightly odd, not odd, but different presentation that this patient had radiation of pain into the posterior thighs. But one of the nice things is that this case report really took into account that multimodal osteopathic approach. In addition to OMT, they were looking at the weight loss that that patient had, the depression, the poor concentration, just that whole person perspective. They did find a type 3 coccyx on this patient. And they used cushions, weight, encouragement. And then the OMT included cranial, cervical, thoracic, lumbar, sacrum, no intrarectal techniques, and they had a reduction of pain in 3 visits. There is an osteopathic case report series that was published in 2017, and they had 50 patients with a chief complaint of coccydynia. They kind of examined and took pain scores of these patients before any intervention was performed, and then after 3 months of medication and physical therapy, and then again after OMT. So there's no different groups, but they kind of progressed through it. So first nothing, then they all had NSAIDs and physical therapy that included massage, pelvic floor exercise, stretching, laser, but no specific treatment of the coccyx. And then, and unfortunately, only showed minimal improvements in their pain scores from an average of 7.12 to 6.5. But then those patients went for OMM. They had 3 visits over 5 weeks of pelvic floor fascial unwinding, treatment of the diaphragm, DLT of the SI joint, OA decompression, lumbosacral decompression, and then intrarectal mobilization using Dr. M's technique. And those, after that, they had an improvement in their pain scores from 6.5 down to 1.2. So a study, a case report series that really has shown some successful reduction in pain scores. So we've talked a lot about Dr. M's intrarectal techniques that gets referenced a lot in these studies. So we'll talk a little bit about him. He first had his pilot study in 2001, where he did a comparison of 3 different types of manual coccydynia treatments in 75 patients with a 2-year follow-up. And so basically took everybody with coccydynia that had been obviously chronic for more than 2 months and excluded them if they didn't want to do obviously intrarectal manipulation or had a low pain threshold or had had prior treatment. And so the 3 groups is that they put those patients into was the first technique was more focusing on massage of the levator ani and coccygeus using a teal technique where they kind of massage those muscles along the long fibers on both sides for 3 minutes, but no mobilization of the coccyx. The second group was really focusing on mobilization, or this kind of Dr. M technique where they grasp the coccyx with the thumb and index finger and then flex and extend and rotate a little bit. And you could augment that technique by applying a little bit of pressure to the sacral base. And then the last group focused on stretching of the levator ani and external sphincter with the index finger until they had contact with the coccyx, but did not mobilize it. So here we can see a little bit the top left of the first group, that teal technique where they have the massage, and then the other 2 are showing pictures of the mobilization of the coccyx using the Dr. M technique. And so they define success with these treatments as at least a 60% reduction in their pain on a VAS scale. And they had a 6-month success rate of 25%, but it did remain there. If they did have success of at least 60% reduction, it did remain there for at least 2 years, which is something to be considered when a lot of patients have setbacks and recurrence. Stretching massage was considered the most effective, but obviously a huge flaw with studies with no control group. So they then did a follow-up in 2006, and they had 102 patients with chronic coccydynia. Group 1 received 3 sessions of intracoccygeal manipulation with mobilization, massage, muscle energy that would kind of slowly increase in intensity on each visit. And group 2 received kind of external physiotherapy, kind of sham, kind of shortwave magnetic PT and lowest possible power, to kind of trying to do nothing. And patients were assessed at 1 and 6 months. And so overall, for group 1, they had a 26% overall improvement in their pain scores, and they assessed them on all these different pain assessment scales. And then at 6 months, again, that improvement seemed to overall continue. So the effectiveness overall was mild, but it definitely seemed to last for a little while. So it kind of then goes to question, is coccygeal manipulation really effective, or should we be focusing on OMT, that is not intrarectal and more focusing on sacrum and pelvis and so on. So Ray et al. In 1991 did a 5-year prospective study on 120 patients with coccydynia, and their inclusion criteria was coccydynia with clinical exam, confirmation, back pain excluded, lots of different etiologies, falls, birth, rowing, cycling, post-surgical, and patients kind of progressed in this stepwise fashion through treatment. So started off with ultrasound, that failed, then they went to the sacrococcygeal injection, so 40 milligrams of declamedrol, 10 milliliters of marcaine, and then injected all around the coccyx, but not through the joint. Then if that failed, then they went to manipulation under anesthesia. And then if that failed, then they went on to a coccygyectomy. So, and this was a kind of stepwise study. So the manipulation that they did, they had the patient in the left lateral position, grasp that coccyx, and then flex it. And it's a little bit of that Dr. M technique. And then they followed those patients for a minimum of a year. And in the pilot phase with the first 50 patients, then 16% of them resolved their pain with ultrasound, 38% had resolution with ultrasound injection, and then 71% had ultrasound injection manipulation had reported improvement in or resolution of their pain. So once that kind of pilot was done, they went on to kind of phase 2, which added in another 70 patients. And those new ones, they randomized to kind of either compare injection versus injection plus manipulation. And just the injection had about a 60% success rate. And then the addition of manipulation increased that success rate to 85%. So that's pretty high. And they define success as being asymptomatic at 3 months. But they did report that they had more than a 20 or approximately, I think it was 21% recurrence of their pain within a year of treatment. So of the 120, 23 patients went on to a coccygyectomy, and 21 of those 23 had full resolution of their pain. Another one that was done was this study just last year, actually, with the 36-month prospective observational single-center study of 115 patients, all adults with chronic coccydynia. And again, about, for a minute, they had coccydynia for an average of 18 months with a pain scale around 6.5 out of 10. They excluded pregnancy and coccygeal fractures, but not dislocation. And then for the first line, they had steroid injections under fluoroscopy. They could have up to 3 a year. And they differentiated on where to do that steroid injection based on the type of coccyx that the patient had. So if there was posterior dislocation or hypermobility, they targeted that disc. If there was normal mobility, then they would target the most mobile disc or the pinch position. And if it was a very rigid or hypomobile coccyx, so that less than 5 degrees of motion, then they would target the spicule that was present or the very tip of the coccyx. But if that patient then had persisting pain despite the injection, then they would either go on to a coccygyectomy or manipulation choice. But not patient choice, it was physician choice. So they put patients into the coccygyectomy category if there was posterior dislocation, hypermobility, or spicule formation, and then manipulation was for the remaining participants. And the manipulation was a minimum of 2 sessions. And they followed these patients for 36 months. They checked on their pain at baseline, 6 months, 36 months. And they had pretty strict thresholds for what was considered good outcome or not. And basically, they were considered to have a poor outcome if their pain was higher than a 3 out of 10 at 36 months. So they reported a 30% success rate at 6 months, 49% success rate at 36 months, and the most helpful being steroid injection followed by manipulation. And then a couple of them felt that it was just like the natural evolution of their course, that not specifically one or the other that was the most helpful. And then 51% of them that still had more than a 3 out of 10 of pain at 36 months went on for the coccydyectomy. So since this was just last year, only 25 of the 59 had a coccydyectomy at that point, and 11 though were set for pending surgery. So what can we take away from that? Well, symptoms, can decrease over time. However, 50% may fail those conservative therapies, and a longer duration is associated with a more unfavorable outcome. Maybe it supports a change in injection style, but again, there's no control groups. And if we would have looked at race studies that had a recurrence, if we had changed the parameters and said, do we need to follow them for longer? Would they've had a higher recurrence? And is a 3 out of 10 pain cutoff too strict? So I know I'm running out of time here, so I'm going to go real fast. Which treatments are most effective overall? Well, basically, radiofrequency ablation is showing the most drastic, but similar is the shockwave coccydyectomy injections. But overall, we really need to do this multimodal approach with non-invasive first and the coccydyectomy as a last resort. And then for our pediatric cases, there's very, very, very little research out there, most of being done all by this group in Norway. There's really only 3 studies total, I think, out there. They have done 2 of them, but 28 adolescents, half got injections, half got coccydyectomies, and overall treatment considered much better at a year. And these were in patients that had kind of failed the conservative. And there wasn't a difference when you case matched them to adults. So the point is, you don't really need to change your treatment approach when you're looking at adolescents. And it's important to treat these patients because you're going to have significant improvements. They've followed them for many years. Improvements in their sitting during class and during exercise. So to summarize, Coccydynia common for acute and temporary, but that chronic is really difficult to treat, really needs that multimodal approach. And the literature just really doesn't have great treatment protocols, but OMT is definitely a valid intervention. It can be effective, intrarectal versus non-intrarectal. So we need studies for that for sure. But that coccydyectomy is last resort, but highly effective, contrary to a lot of popular beliefs. So my references here, and then I'm just going to leave the screen up because, I'm one of the people that reviews your osteopathic documentation in the hospital, and recently we've had some documentation failures. So just as a reminder, it's a little little note from me, a love note. When you're doing those HMPs, you have to remember on your osteopathic exam, document at least one area in 2 different positions, okay? So seated and supine or whatever, okay? Not 2 areas of one position, right? So make sure it's at least one area of 2 different positions. If you can't check 2 positions, just document why. Maybe they were drunk, maybe they're intubated, sedated, or maybe they need to go to the OR immediately. Just put a little blurb as to why you couldn't do it. All right, guys, thank you so much, and I will see you around.